It is now my pleasure to introduce our speakers. Stephanie Wynn, MD, FRC PC, Clinical Associate Professor, University of Calgary, Calgary, Alberta, Canada. And Stephanie Wilson, MD, FRC PC, Co-President of ICUS, Clinical Professor of Radiology and Gastroenterography, University of Calgary, Calgary, Alberta, Canada. Dr. Wilson.
Thank you very much. So I'd like to express a welcome to you from the co-presidents of ICUS. So on behalf of the International Contrast Ultrasound Society, we are pleased to extend a warm welcome to all participants in today's webinar. We also want to thank all those who have helped plan today's program, starting with our esteemed faculty who are widely respected leaders in the field of contrast-enhanced ultrasound and are deeply committed to helping ICUS provide quality education. And we want to express great appreciation to our wonderful friends from Northwest Imaging Forums, the exclusive CME provider for ICUS, for their support of our educational program. And I will tell you that in all of my experiences, there has never been a flaw from them. So we do appreciate that we can have webinars like this run without problems. And we thank each of you for your interest in today's webinar and encourage you to register and join us for all ICUS live and recorded webinars available on our website and mobile app, ICUS Connect. So on behalf of myself and Steve Feinstein, my co-president, welcome. So what about ICUS? So ICUS is the only global professional society that is solely focused on contrast-enhanced ultrasound. We now have members in 60 countries comprised of physicians, sonographers, nurses, scientists, industry, and patients. We represent radiology, cardiology, hepatology, vascular and GI medicine, and many more. ICUS never charges fees for anything, which I think is a really incredible fact. So it's free for membership. And if you would like to hit our QR code, you can join now. We offer free webinars and CME credit with AMA and SDMS credit available. We have a free website and a mobile app called ICUS Connect, where we can see webinars, sponsor virtual exhibits, case of the day challenges, sonographer training hub with CEUS modules and product labels, bubble blogs, bubble TV, and more. And free CEUS news monitors are sent and with the latest bubble news and trends to our membership in 60 countries with English, Mandarin, and other translations available. So our commitment to contrast-enhanced ultrasound is an essential tool for modern ultrasound labs throughout the world for more than 2 decades. CEUS is a safe, portable, and radiation-free modality which produces high-resolution, real-time images of the cardiovascular system, major blood vessels, and organ and tumor perfusion. Further, it reduces downstream testing, improves hospital workflows, and speeds access to diagnosis and therapy. And so our commitment to free CEUS education, I believe, is incomparable. So this is for physicians, for sonographers, nurses, and other ultrasound professionals. We are working now within our 2024 calendar, and registration is available, as you can see, at our website. And we are now working and about to release our 2025 schedule as well. All of the live webinars are recorded and available free of charge on the ICUS website and the mobile app ICUS Connect. So from here, I'm just going to mention a few things. On Instagram, we now offer our case of the day, a wonderful educational opportunity. We have a training resource hub where there are free CEUS training tools for sonography educators. You should please download ICUS Connect, which is your gateway 24/7 to CEUS and all related new items. We have a CEUS news monitor, which is sent once every 2 weeks with global trends and developments. and please explore the ICUS website. So we want to encourage you and your colleagues to join ICUS, and you can see that we are part of a global CEUS conversation with ICUS Connect, the ICUS website, X, or formerly what we liked better, Twitter, and Instagram. And so with sincere appreciation, we would like to recognize our sponsors for their generous support of ICUS and their leadership in the field of ultrasound. And so you can see here our platinum, gold, silver, and bronze sponsors, and note that Northwest Imaging Forums is one of our bronze sponsors. So with that, we'd like to go to today's agenda. And so we're going to speak to you about contrast-enhanced ultrasound in pregnancy and gyne oncology. We think these are two somewhat unfamiliar arenas, and we hope that you will enjoy these presentations. And they're very key items at the University of Calgary CEUS department. So to begin our program, I'd like to call on my colleague, who's also Stephanie Wing, who will talk to us about CEUS in pregnancy. Stephanie.
All right, thank you for joining me. I'd first like to go into the first half of this presentation, which is going to be about use of CEUS in pregnancy, what we'd like to think is a safe and effective diagnostic tool. We have some acknowledgements. Dr. David Burrows, a colleague of ours at the Foothills Medical Center in Calgary, and Christine Merrill, charge sonographer in Dr. Wilson's ultrasound department. These are our disclosures. As a brief outline, we'll begin with an introduction. We'll talk about the complexity of imaging in pregnancy, namely the limitations of CT and MRI. And we'll go into contrast-enhanced ultrasound as an alternate to CT and MRI during pregnancy. We'll follow this up with case examples of CEUS applications during pregnancy. The main three things we've found CEUS is most helpful for is workup of acute presentations, imaging chronic disease, and characterization of benign and malignant lesions. As you're all well aware, there are complex problems related to imaging of the pregnant patient. With CT, the primary consideration is radiation. The effect of CT radiation depends on the dose and the gestational age at time of exposure. The risks include spontaneous abortion, fetal malformations, fetal growth restriction, cognitive delay, and increased risk of childhood cancer. When it comes to CT iodinated contrast, we know it crosses the blood placental barrier and into the fetus. In vivo animal tests, there are no mutagenic or teratogenic effects with low osmolality iodinated contrast. Previously, there were rare reports of neonatal hypothyroidism, but these related to amniophetography. So this was previously performed to detect congenital malformations and was done with fat-soluble injected contrast, which we no longer do. There are no documented cases of neonatal hypothyroidism from maternal IV water-soluble iodinated contrast. So the American College of Radiology, or ACR, does not recommend withholding the use of iodinated contrast when needed for diagnostic purposes. MRI, this technique may be cumbersome for the pregnant patient based on bore size and the prolonged exam time, especially at later gestational ages. There are possible teratogenic effects of MRI in the first trimester suggested by animal studies. For MRI contrast, gadolinium-based contrast agents also cross the blood placental barrier. They pass into the fetal circulation and then are entered into the amniotic fluid and swallowed, leading to extended exposure to gadolinium. There are teratogenic effects in animal studies at high and repeated doses. There are no mutagenic effects of gadolinium-based contrast agents in human fetuses when clinically recommended doses are given to pregnant women. There are no known cases, but there is a theoretical risk for development of nephrogenic systemic fibrosis, or NSF, in the parent or fetus, as gadolinium chelates may accumulate in the amniotic fluid. The current ACR recommendation stance is it's unclear how gadolinium-based contrast agents will affect the fetus. Thus, they should be administered with caution to pregnant or potentially pregnant patients if usage is considered critical and potential benefits justify the potential unknown risks. Ultimately, CT is restricted in gravid patients due to the ionizing radiation, and MRI technically may be limited by the absence of contrast media. Now, we know ultrasound is the primary test for imaging in pregnancy for both obstetric and non-obstetric conditions. CEUS is a valuable adjunct to standard grayscale and Doppler ultrasound. It's well tolerated, repeatable, and capable of assessing multiple organs and areas. It provides similar vascular information gained from contrast-enhanced CT or MRI, and it has a long history of safe use in cardiovascular and abdominal settings. There are few studies that exist as to the safety of CEUS microbubble contrast agents in pregnant patients. From the limited studies, what we do know is that there's successful use of CEUS to evaluate these patients with no observed adverse maternal or fetal events. Unlike CT and MR contrast, microbubble contrast agents do not cross the placental barrier. Animal studies have shown no fetal harm of sulfur hexafluoride lipid microbubble doses at well above those used in clinical human practice. Here we present our experience with CEUS in pregnancy with case examples. For all of our patients, we did not observe any adverse maternal or fetal events. So CEUS, workup of acute presentations. Case number 1, this is a 31-year-old at 21 weeks who presented with acute pain and a palpable mass. On the sagittal ultrasound cine clip there, you can see a solid and cystic mass superior to the gravid uterus, which has a fundal placenta. On MRI, we see again this solid and cystic mass, and the possibility of a degenerating fibroid is raised. Obstetrics would like to exclude the possibility of malignancy, however. When we take this patient to CEUS, the mass is completely avascular, which supports the diagnosis of a degenerated pedunculated fibroid, shown here. This is an intraoperative image showing the large fibroid and the pedicle at time of myomectomy, performed at 21 weeks given the acute presentation. This patient went on to carry to term without further issue. Second case is a 26-year-old with severe pain, a known large fibroid, and clinical question of complication. Again, on the sagittal cine clip, you can see a large, solid and cystic mass. It's about 30 centimeters in size at the uterine fundus. No vascularity was seen on color Doppler evaluation. When we perform CEUS, the fibroid is completely avascular, shown here. As we pan through from the avascular fibroid into the uterus, you'll see that there is enhancement of the placenta, shown here. There is apparent enhancement of the fetus. However, this isn't true enhancement. This relates to nonlinear artifact on echogenic fetal structures. As you will recall, microbubbles do not enter the fetal circulation due to the placental barrier. Overall, the appearance of an avascular fibroid is consistent with fibroid infarction. This patient was managed conservatively and went on to an uncomplicated vaginal delivery after scheduled induction of labor at 37 weeks and 5 days, given the known large fibroid. Our third acute presentation, this is a 27-year-old at 24 weeks with Crohn's disease, presenting with increased CRP, bloating, episodic vomiting, and pain. On this long axis image of the terminal ileum, you can see a 2-centimeter stricture outlined by the dash at the ileocecal valve. There's dilation of an upstream loop, which is content-filled. Short axis image of the terminal ileum shows wall thickening, hyperemia, and on CEUS, we found evidence of moderate active inflammation with a peak enhancement of 20 decibels. We also performed elastography of the bowel, which showed 1.6 meter per second median shear wave speed. In our experience, this suggests moderate increased bowel wall stiffness. The ultrasound CEUS diagnosis is that of active stenosing Crohn's disease with a TI stricture with both inflammatory and chronic components, resulting in incomplete mechanical bowel obstruction. Given the evidence of active inflammation, gastroenterology initiated prednisone. This is a 6-week follow-up ultrasound on the same patient. You can see persistent stricture here outlined with persistent upstream bowel dilatation. There's decreased hyperemia on this color Doppler image, and the patient's symptoms had improved. They had no further Crohn flares and continued on to a term delivery. Our second category is CEUS and the imaging of chronic disease in pregnant patients. This is a 43-year-old in first trimester, 8 weeks and 5 days, with HBV presenting for HCC screening. On that exam, they found an echogenic observation measuring 17 millimeter, as well as a sub-centimeter observation measuring 8 millimeter. At CEUS, that echogenic lesion demonstrates classic discontinuous peripheral nodular enhancement. This is the arterial phase CEUS showing that peripheral puddle. On 12, 1 minute, and 5 minute images, you can see progressive enhancement with no washout. This is consistent with a benign hemangioma. Now you recall they also had a sub-centimeter observation. This would be technically considered subthreshold. However, with CEUS, you can exquisitely see as a cine clip replays discontinuous peripheral nodular enhancement shown on these still images. This is another classic hemangioma. There's no washout seen at 5 minutes. This patient was able to be reassured of a benign diagnosis and continued on with routine care. Our second case is a 40-year-old at 32 weeks with Crohn's disease and severe postprandial bloating. This is a long axis image of the terminal ileum. There's severe thickening over a 5-centimeter length. There's luminal apposition and pre-stenotic dilatation shown here. Short axis images of the bowel again show mural thickening, no hyperemia on the color Doppler image, which is not shown. And then this is an elastography image. In this patient with chronic Crohn's disease, we see the median shear wave speed of the bowel is 3.9 meters per second, which in our experience is severe increased bowel wall stiffness. At CEUS, the peak enhancement was at 15 decibels, which suggests only mild active inflammation. Overall, the increased bowel wall stiffness and low inflammatory activity at CEUS suggests a chronic TI stricture, and surgical consultation was recommended. This patient thus had no change to weekly Humira during their pregnancy and went on to a term delivery. Postpartum reassessment showed no significant change in the ultrasound findings, and given their ongoing symptoms, they are scheduled for an ileocolic resection. Our third major category is characterization of benign and malignant lesions encountered during pregnancy. This is a 32-year-old at 20 weeks with a growing liver lesion. On the grayscale ultrasound, you can see a multilocular cystic liver mass. It has many septations. No flow is seen on these septations on color Doppler. However, when we do the CEUS, you can see exquisite bubbles tracking in all of these septations. The septal enhancement began in the arterial phase, with washout beginning before 1 minute, and the possibility of a mucinous cystic neoplasm of the liver was raised. At the same time as CEUS, we always look at the fetus. In this example, you can see, again, the placental enhancement and no microbubble contrast in the fetus. This patient was referred to hepatobiliary surgery, and resection is scheduled 6 months postpartum to allow for a window of breastfeeding prior to resection of this lesion. This is a 30-year-old at 8 weeks in the first trimester who had a cystic ovarian mass detected on outside clinic ultrasound. The outside clinic ultrasound suggested it was multilocular. When we do CEUS, those fine strands within the cystic lesion are completely avascular. This is consistent with a benign hemorrhagic cyst containing fibrin strands. Again, this is a example CEUS image centered on the uterus and gestational sac. On the grayscale, you can see the embryo here with no microbubbles in it on the CEUS image. At the time of evaluation for this ovarian mass, the patient was also incidentally found to have a gallbladder polyp. On grayscale and color Doppler, you can see this pedunculated polyp measuring up to 1.8 centimeter with a vascular pedicle. On CEUS, we demonstrate nicely the enhancement of this polyp with washout. With the size of this polyp as per Society of Radiologists and ultrasound recommendations, this patient went on to surgical resection. So they had elective cholecystectomy post-term delivery, and that final pathology was negative for dysplasia and malignancy. Our next case is a 43-year-old at 28 weeks with chronic Hep B virus and Hep D virus cirrhosis. They have a nodular cirrhotic liver, and multiple hypoechoic observations were seen, including a dominant observation in segment 7-8 measuring 17 millimeters. The patient had a non-contrast MRI during pregnancy, which showed a subtle lesion on the T1 out of phase sequence here. There was no abnormality on T2 or DWI. This is a LIRADS non-categorizable lesion in the absence of contrast. However, they can have CEUS. And so on CEUS, that observation shows arterial phase hyperenhancement and late mild washout consistent with a LIRADS 5 hepatocellular carcinoma. This patient went to multidisciplinary discussion with a plan to deliver at 36 weeks, followed promptly by staging enhanced MRI and ablative or surgical management. Case 4, this is a 39-year-old with a growing ovarian mass. On outside ultrasound exams, you can see the evolution of this mass here, but I will save this exam for Dr. Wilson to share the outcome in a couple of minutes here. Our next case is going to be a 39-year-old with a solid adnexal mass, which was detected on dating ultrasound. So there's the mass on dating ultrasound. It's solid, it's vascular. A left ovary was not identified separately. At time of first trimester screen, they saw this mass again, and it was unchanged. The patient was sent for an MRI, and the MRI suggested that the left adnexal lesion was no longer present. However, when we retrospectively review this outside MRI, we can see that their field of view was inadequate and that the solid mass is actually present, just changed in position, now seen at the superior edge of the gravid uterus. When we evaluated this patient on ultrasound, we can see a solid mass at the superior margin of the uterus connected with a vascular stalk. So here is that vessel on grayscale, and here's that vessel on power Doppler. CEUS much nicely shows enhancement of the uterine vessels, which extend into this solid exophytic mass, which is consistent with a pedunculated Figo-7 fibroid. The patient was able to be reassured and went on to an elective C-section at 38 weeks, at which time the pedunculated fibroid was confirmed and myomectomy performed. Our next case is a 36-year-old at 30 weeks with a growing cystic adnexal mass. This patient was referred to us, and their initial imaging workup, they had an unenhanced MRI, which showed a multilocular cystic ovarian mass without a solid component. On Doppler, there is some flow within the septations. However, on CEUS, you see much more exquisitely septal enhancement throughout the multilocular cystic mass. The appearance is suggestive of an ovarian mucinous cystadenoma. This patient underwent scheduled C-section and right salpingo oophorectomy at 37 weeks, which confirmed our suspected diagnosis. This is a 31-year-old at 20 weeks and 6 days gestational age, presenting with right flank pain. Ultrasound at that time showed a large 5-centimeter echogenic mass in the right kidney lower pole with vascularity on color Doppler. The patient went on to an unenhanced MRI, which showed the mass was hypointense to renal cortex. On T2 weighted sequences, there was no intralesional microscopic or macroscopic fat on MR, but otherwise MR had no additional contributory information in the absence of IV contrast. CEUS was performed showing arterial phase hyperenhancement with rapid washout beginning less than 1 minute, consistent with a malignant mass or renal cell carcinoma. This patient went on to a biopsy confirming a chromophobe subtype RCC and nephrectomy at 22 weeks gestation for definitive management. She subsequently went to term without any issue. This is a similar case, a 32-year-old at 17 weeks and 2 days with an incidental right renal mass. Here you can see a heterogeneous solid exophytic mass from the right kidney lower pole with vascularity on color Doppler. When we do CEUS, the mass shown here shows rapid enhancement as avid as the renal parenchyma with washout occurring after 3 minutes. The patient went on to biopsy. This confirmed a chromophobe RCC, and like the other patient, went on to intrapartum nephrectomy for definitive management. She also continued to term without further issue. So in conclusion, CT and MRI are limited in pregnancy. The primary consideration for CT is the use of ionizing radiation. With MRI, it's going to be the use of gadolinium-based contrast agents. So MRI, unenhanced MRI, often adds no new information to that which is already shown on ultrasound. CEUS is safe in pregnancy. The microbubble contrast agents do not cross the placental barrier and thus pose no harm to the mother nor the fetus. We suggest CEUS as an effective alternate to CT and MRI in pregnancy, and it should be considered a useful problem-solving tool and possible first-line imaging test in select settings. So for our experience, workup of acute presentations, diagnostic clarification, and assessment of pre-existing disease. The major indication for CEUS is in the determination of malignancy when masses anywhere in the abdomen or pelvis are found during pregnancy. The ability of CEUS to differentiate benign from malignant processes allows prompt diagnosis and management with significant implications on maternal and fetal health. These are some of the references you saw during the presentation, and then I'll now switch to Dr. Wilson's.
Thank you, Stephanie. I'm sure I speak on behalf of everyone that was a wonderful, wonderful presentation. And following this presentation, we will both welcome questions. So I'm going to now change gears a little bit and talk about innovations in ultrasound of the ovary, the application of CEUS. And I'd like to acknowledge my co-author here, Kelsey Briesbaugh, who's a wonderful, talented junior sonographer in our department, and also my team of people who do CEUS with me at the University of Calgary. So I have no relevant disclosures to this presentation. So when we consider ultrasound and contrast-enhanced ultrasound strengths, what are they? Well, first of all, ultrasound is always a dynamic and real-time assessment. Scans are produced with an inherent narrow scan plane using a subtraction technique for the production of CEUS images. This avoids volume averaging pitfalls and provides extreme sensitivity to blood flow, superior to Doppler and, in fact, to other imaging cross-sectional modalities. It allows us to distinguish true solid components from dense cyst contents, which is always a problem otherwise on ultrasound, and the purely intravascular microbubble contrast agents that are used always reflect the vascular bed. This allows us to determine accurate arterial hyperenhancement and washout with high correlation to malignancy. In addition, no interstitial contrast obscures the presence of washout, as occurs with CT and MR scan. So what are the existing CEUS applications that are well accepted? Of course, the original approval was for liver use, and ultimately both liver and kidney, I believe, are well established in clinical work. And so for both organs, when we're looking at tumors, we're considering both solid and less common complex cystic solid lesions. And so we recognize the ability of CEUS to show vascularity within solid tumors, as well as thin septations and tiny nodules within complex masses, is highlighted in diagnosis. And so certainly the latter is best known for cystic renal cell carcinoma and mucinous cystic neoplasms of the liver, of which Stephanie has already shown a wonderful example. So let's look at an indeterminate CT scan on a 67-year-old male with a right renal mass. So this is a good quality CT scan with contrast, and it shows a common problem of the indeterminate renal mass, where the CT reports here a suspect or a cystic mass with suspect thin septae, and you can appreciate the fine evidence of these septa on these scans. So if we add CEUS to this patient, we can see immediately that the grayscale alone has superior spatial resolution to CT and MR scan, and we can see that the detail of the septations, some thin, but others thicker. And then when we add contrast enhancement to this, we can see even more here when we're looping the clip, and we can see when the microbubbles arrive that they instantly opacify the septa, and we can see within this that this is a significant lesion, and this is a proven cystic renal cell carcinoma. And so let's look again at another liver case. and showing the spatial resolution from volume averaging. So in this patient, a 71-year-old patient, an incidentally detected liver mass is shown. So on the thick slices that we have on the MR scan, blood flow is averaged with surrounding fluid, and it may mask true enhancement within this cystic mass. So MR reports this as showing no enhancing nodules within this complex cystic mass. Again, if we add contrast-enhanced ultrasound, on the left you can see the grayscale image doesn't differentiate whether this is cystic or solid. However, when we inject microbubbles, we can see that the mass is in fact dominantly cystic, but you can see very easily that there are hyper-enhancing nodular areas within this mass. And this, of course, was suspicious, and this is leads us to recommend that this is a malignant lesion. So the good news we get from these two cases is that CEUS, in fact, excels in cystic complex lesions, and this was established in our familiar applications in the liver and the kidney. And so we feel as though it's appropriate that we take these applications from proven benefits and transfer them to the ovary. So our hypothesis is that CEUS is ideal for evaluation of ovarian lesions, as it is for cystic lesions everywhere. And so, of course, the most common morphology, gross morphology for ovarian lesions is a cystic complex mass. So ultrasound in ovarian imaging is already established. So standard ultrasound is a first-line imaging investigation for all ovarian pathology. And so this is performed with both transabdominal and transvaginal assessment, where we use grayscale and color Doppler imaging techniques. And now today, of course, we have new innovations added to our endovaginal probes in particular that allow us to assess time of arrival, super resolution, and also to perform quantification of blood flow. So we know that ultrasound is readily available in hospital ultrasound departments and in private practice, and it comprises standard and emergency care for gynecology patients. And an important facet is that it's well tolerated by virtually all patients. So let's consider ovarian tumors. What are the challenges? Well, first of all, there are a very large number of patients with mass lesions in their ovaries, and this includes women at all ages throughout their life. And these present clinically and require imaging for further clarification. Further, there's a significant overlap of features in ovarian tumors between benign and malignant lesions. And as already stated, these lesions frequently present with mixed solid and cystic morphology. Now, ovarian cancer has a noteworthy spectrum from borderline to high-grade malignant lesions, which have similar morphology. So all of these things are considerations when we propose doing CEUS for patients with possible ovarian tumors. Now, I certainly do not expect you to read this small print, but at the top, you'll see that we've outlined in this chart the sonographic appearance of masses, and they extend from simple cystic mass on the left through to the solid mass shown in black on the right. And in the middle are all the complex cystic variations. And there are multiple tumors for us to consider on the left-hand column. The most common neoplasms are of epithelial origin, including especially serous, benign and high-grade serous tumors, mucinous lesions, and less frequent solid tumors, the Brenner tumor and the adenofibroma. In addition, we have germ cell neoplasms to consider, sex cord stromal neoplasms, and other rare and less frequently found tumors. And so certainly it is in this area in the center where we believe that the special applications afforded by CEUS will be of benefit. So what are our objectives when we look at the ovary? Well, of course, we want to confirm benignity, and this, of course, is proposed when we show an avascular content, which always supports a benign outcome. And so what the goal with determining that patients have a benign lesion is to decrease unnecessary follow-up and downstream testing. However, we also want to be sensitive for suspicion of malignancy to improve the detection and characterization of malignant features. And the goal, of course, here is expedited care. So let's look at a case. So these are two cases, in fact. So case 1 on the left and case 2 on the right. So both of these images are endovaginal scans looking at an ovary. And on both of these, there is a solid mass in the ovary. And when I put pink coloration on the ovary, you can see that the remainder of the tissue represents the solid mass. So they both show normal ovary as well as these solid areas. And so when we add the CEUS to the study of these patients, you can see that case 1, when we inject the microbubbles, is clearly virtually all solid with hyperenhancement and then rapid washout. Whereas if we look at case number 2 on the right, we can see very easily that our dominant mass is completely bubble-free. The enhancing ovarian parenchyma with follicles surrounds it. Now, when we look at these still images taken from these cases, you can see that case number 1 with a solid and hyper-enhancing mass is possibly malignant and requires further investigation. Whereas the mass on the right, which is cystic and avascular, is definitely benign and no follow-up is required for this patient. And so how does this add value to our clinical assessment? Well, the cycle of follow-up, which often goes on almost into perpetuity, is changed. So whereas ultrasound follow-up frequently is recommended from ultrasound scans, or ultrasound may recommend MR CT scan, which tends to often recommend repeat exams of their own. Whereas if we add CEUS, you can see that following the initial investigation, if we show a clearly benign lesion, no follow-up, either ultrasound or CT-MR would be required. Whereas if we show vascularity, further investigations, including especially MR scan, may be appropriate. So CEUS break the cycle and reduce unnecessary follow-up. So let's look at another patient with a classic lesion with contrast-enhanced ultrasound. So you can see on the grayscale scan that this patient has got echogenic masses within this ovary. And what do they suggest? Of course, the familiar dermoid cyst. And so in this patient who's had a previous oophorectomy for cystadenoma with mature teratomas, these echogenic masses in the right ovary are suspicious. When we add CEUS and focus on one of the echogenic lesions, you can see that as the microbubbles come into the ovary, that the ovarian tissue is enhanced, the follicles show, whereas this echogenic nodule is virtually devoid of microbubbles, confirming the suspicion for a mature teratoma. So let's look at another patient. This is a 66-year-old female who knew that she had an ovarian cancer of unknown type removed in 1985, so many, many years ago. She had a hysterectomy and bilateral oophorectomy at that time. And so her MR scan here shows a size-stable adnexal mass with a vaguely hyper-enhancing internal nodule shown by the yellow arrows. And so this is somewhat of an indeterminate result. And so this patient comes for ultrasound, and we have instant suspicion of malignancy when we identify a cystic mass with low-level echoes and the arrows pointing to obvious internal mural nodules. So this patient then goes, of course, to CEUS, as we always look for mural nodules with CEUS, and we can see that we're focused on the nodules, and that when the microbubbles come in, there is no doubt that there are microbubbles and enhancement within 2 nodules that are shown there. And then on the image on the right at 3 minutes, you can see that these hyper-enhancing nodules have washed out. So we suggested the probability of recurrent low malignant potential tumor when we considered both her history of a very remote oophorectomy for tumor and the contrast-enhanced ultrasound showing enhancing papillary nodules. And this was confirmed at surgery as serous borderline tumor, confirmed many, many years after her original resection, and really reflecting the typical pathway for these low malignant potential tumors to not kill the patient often and to be around for a very long time. Now, this is an interesting and rather entertaining case. So this is a patient with increased abdominal girth. And so she's a 40-year-old patient, and she was identified to have a left ovarian cystic mass that showed swirling low-level echoes within. And so the initial impression is that this would be a benign hemorrhagic cyst. And so, of course, I probably have the lowest threshold for performing CEUS for many things, including any complex ovarian lesion. So, of course, we sent this patient for CEUS. And when we start out our CEUS, it looks like this is just a cyst. However, you can then see that there's an enhancing nodule in the bottom right corner of that cyst. And so this is certainly suspicious for ovarian malignancy and shows that CEUS provides value even in lesions initially interpreted as benign. This patient went to the operating room, and this is a confirmed endometrioid carcinoma of the ovary. So in case 2 and 3 that I've just shown you, there have been papillary growths of significance within the ovary. And so solid papillary growths are concerning at baseline grayscale ultrasound. And this is true in patients of all age. This is a 17-year-old girl, and this is a low-grade papillary serous malignancy. So we have to be suspicious for papillary growths. CEUS is excellent to show vascularity within these lesions. And of course, another case, a patient, 35-year-old female with an incidental ovarian lesion on a biophysical scan. This is a postnatal assessment of this lesion. And here we have, again, very suspicious grayscale morphology suggesting a mucinous epithelial lesion, which again is confirmed at surgery. And when we do CEUS on this lesion with these septa, again, you can see the value of doing the CEUS in that we show quite avid vascularity in this patient with no solid papillary nodules and no washout. So this is the case that Stephanie kindly let me take into this presentation. So this is a patient who was referred to us at 30 weeks gestational age. And so she was pregnant, and you can see that on her 5-week scan, her 12-week scan, and on her 20-week scan, that she has a growing complex mass in her ovary. Now, had she come to our department at 5 weeks, 12 weeks, or 20 weeks, it wouldn't have mattered. We would have done a contrast ultrasound. But when she does show up to us, in fact, she doesn't come till 30 weeks gestational age, at which time her mass measures 21 centimeters in diameter. So this is an ominous history and suggests a high-risk lesion with progressive rapid growth and vascular septations in this mass. And the most difficult aspect for CEUS, I believe, is not in determining that we think this is a neoplasm. It's in determining where we think it falls in between low grade borderline, and then high-grade lesions. And so this patient did have surgery intrapartum, and this is a mucinous borderline cystadenoma, but this rapidly growing tumor was actually leaking at the time that this was removed surgically, which has onerous consequence. And I regret always that this patient was not referred to us at 5 weeks gestational age, and perhaps in the future she might be. And to make the point again, this is a young lady we saw recently with bilateral ovarian masses at 19 years of age. And these masses had doubled in size in the prior year. So the baseline ultrasound shows a mixed cystic and solid appearance with low-level echoes within the fluid. And there is normal ovarian residual tissue in both ovaries. And so this patient also goes on to CEUS, and you can see that that solid appearing area is hyper-enhancing initially with very rapid washout. So this is strongly suggestive of this as a malignant tumor. So this is concerning, but even the grayscale alone is concerning in this patient. And in this case, this is borderline serous tumor confirmed at pathology in both ovaries in a 19-year-old. And of course, if these lesions are left, ultimately there's no normal ovarian tissue at the time when they might come for surgical consultation. And so I think this is my last case. This is a patient with a solid ovarian lesion, and we can see that I have this colorized, and you can see that the tumor is there in orange, and in front you can see an atrophic uterus with calcifications in the vascular structures. And so this patient also, of course, has a valuation of her entire abdomen where we show additional grayscale findings in the form of an omental cake, which you can see here also with coloration. So the presence of peritoneal disease instantly escalates concern for malignancy, and we add contrast enhanced ultrasound. We can see again very, very avid hyperenhancement of this solid neoplasm, which has again quite rapid washout consistent with a malignant outcome. And this is a high-grade serous carcinoma with peritoneal metastasis. And of course, serous carcinoma has the highest association with peritoneal disease. So our experience with both liver and now ovarian malignancies is that LIRADS, the standard that's used for the liver, boasts a 96% specificity for hepatocellular carcinoma in the category LR5. So the ovary seems to us to lack the similar stringent criteria that allow for malignant prediction. But in the liver and the kidney, small internal nodules and septations are highly suggestive of malignancy alone, whereas this is not necessarily the case in the ovary. And so our experience with the ovary is that there's a big overlap in the morphology and the CEUS between benign and malignant tumors, especially those epithelial tumors. And to identify malignancies with acceptable sensitivity, there likely has to be a compromise on the specificity. So we expect that some benign lesions will always end up with surgical management. So what we are doing right now is that we try to classify lesions using the standard ORADS categorization material that we have. And so then what we do is we take these lesions, so starting with our cystic, our complex lesions, and ultimately our solid lesions on this side. And then we do CEUS on them. And obviously, if we have no enhancement, we might de-escalate anything that we've seen from either clinical presentation or from previous MR. Whereas if they enhance, then we evaluate them relative to all of the features that we see, and then try to either maintain the ORADS category or escalate them if we show evidence of features that weren't shown on the original ORADS. And then the new developments that we have in CEUS include blood flow quantification available on endovaginal probes. And so these allow us to generate time intensity curves and then to do region of interest quantifications. And so we are hopeful that in the future, this might help us to differentiate more benign from more malignant lesions. And then here at the bottom, we're also showing you our super resolution imaging with time of arrival, which shows that beautiful solid mass that I have just shown you. So this is things that we will evaluate in the future. So in the future, we believe there's room for growth in the literature, and certainly there's no established criteria for CEUS in ORADs or other models. And so we ask ourselves, or we've posed to ourselves the question, can addition of CEUS improve performance of the ORADS algorithm? And we will use time of arrival, super resolution, but most importantly, I believe, will be quantification techniques where we can apply region of interest assessment to assess the flow patterns within the internal components of particularly cystic masses. So in conclusion, we feel that ultrasound is already a first-line modality to characterize gynecologic lesions. It has superior spatial resolution and accurately identifies small septations and nodules. And microbubbles confirm the presence of blood vessels for superior contrast resolution with the highest available sensitivity. So we hope that CEUS will provide a great potential as a primary diagnostic tool in ovarian lesion investigation. And these are just some of my references, and I thank you for your attention. And so we'll go back now, and I welcome my co-presenters, the other Stephanie, and we'll both like to address any questions that you have for us. And Matt, if you feel that some are good ones, you could direct us to those.
Absolutely. So those of you, if you could put your questions in, we have a few there.
So we can see one question from Victor saying, "Dear Dr. Wilson, as I've seen, we can contrast the placenta, but no umbilicus and fetus. Can we estimate the condition of placenta by CEUS?"
Placenta protruda. Oh, yes. So the answer is yes. Do we do it? We have been asked to do it. And do we do it right this moment? No. But so I don't have a really good answer as to how well we would do. But the placenta is well visualized on CEUS, and that is one of our future endeavors to investigate this further. So thank you for the question. So how often is CEUS being used in the United States? Or is that in ultrasound? Ashton, can you answer that? What do you think it is in the US? In the US. Okay, we'll answer it as if you're asking in the US. So in the US, you don't use it as much as we do, but nobody uses it as much as we do. There's reasons for that. So the FDA, like we got an approval for microbubble contrast agent use in Canada in the year 2002. And that was about the time that it was approved, bubbles were approved in Europe and also in Asia, not completely, but mostly in Asia. And so we started to use them vigorously even before 2002. And so the microbubbles for radiology were not approved until 2016. And so I believe that part of the problem with the adoption of the microbubble imaging in the US is that time frame from 2000 until 2016 was very important. Many places were increasing their use of CT and MR. There was more guidelines made for using CT and MR. The ACR guidelines and others did not include CEUS, and so we've been working hard to increase those numbers, but there are obstacles which are unnecessary. Now, the other problem I believe that has occurred in the United States and in Canada is that the lack of sonographers are an essential component of ultrasound departments in North America. And this integration of sonographers into ultrasound departments creates a situation whereby physicians who may not be as familiar with doing CEUS are uncomfortable to go into a department that's doing CEUS. So there's reluctance on the part of the physicians and also administrators that there's sufficient expertise on the sonography side. So in the last 5 years, there has been a dramatic escalation in the education of sonographers, including real good activity to allow expanded IV starts from sonographers. So while CT and MR techs have been approved to start intravenous or to gain intravenous access for many years, only more recently has this spread for us to be able to involve sonographers. So I hope that these things will all be lead to increased utilization of CEUS in the United States in the future. Increased education, increased exposure, and guidelines which are more receptive to the use of CEUS.
Yeah, no, I agree.
What else do you see?
And then our next question is CEUS considered a procedure in the US?
Oh, well, I can answer that. It is a great procedure. So in the US, you have perhaps the champion person that I know in the whole world who negotiated for the CPT codes for CEUS. So in the United States, it's a wonderful situation, and it's much better than what we have in Canada. So you can get approval payment to perform procedures that are on label and off label. You can use any contrast agent, and you can be paid on the number of items that you look at. In other words, if you did a liver and a kidney, you could make 2 CPT codes. And so yes, CEUS is considered a procedure. It's increasingly mentioned in all of the national guidelines. It's now in the ACR information. And so that, plus the fact that from a billing perspective, it's very, very good for the United States.
Our next question is, what mechanical index should you not exceed when using contrast enhancement agents for OB-GYN and abdominal imaging?
0.8.
I think so. Yeah.
My techs are right outside the door. They would probably answer that for me. I think it's very low. 0.8 is about it. So we want to do, when we're doing contrast enhanced ultrasound, we're using low mechanical index scanning to preserve the microbubble population. So we cannot increase the MI, otherwise we will destroy our microbubbles. And so we want to resist the temptation to turn up the MI. Oh,
yeah. Our next question is, how did you, our next question is, how did you persuade gynecologists and other specialists to refer pregnant patients to CEUS, as they're always very cautious with pregnant patients?
Well, actually, I don't know how to answer that question. Like, so when we became interested in doing pregnant patients, it's actually the interaction between the radiologist and the pregnant patient that really determines whether we can do it. And so we always, this is a great question because you make me answer a slightly different question. So whenever we do a pregnant patient to this day, we always encourage them, first of all, if they're with their significant other or someone with them, if we're not, then we have them both in the room. We explain the procedure. We explain the safety record. We explain what we believe to be the situation in terms of the microbubbles not crossing the placenta and not having any impact on the fetus. And then we give them lots of opportunity to ask us any questions that they want. And we also give them the opportunity, especially in our earlier scans, that if they would like to reconsider or discuss with their doctor and come back, that would be fine as well. But now that it's more, we've presented this material, for example, Internationally, we're trying to publish this right now, and we also have presented it at our OBGYN rounds within our own institution. So now that it's more familiar, people do send more cases to us, and patients, as once they've had this explained to them, we haven't had any problems. No.
Next question is, what amount of contrast agent do you apply in pregnant patients?
Yeah. So we use the same dose of contrast agent for a pregnant patient as we would use to do a liver scan on the same patient. And so that's a very, very good starting place. So in other words, we would examine the organs or whatever we're looking at just the same as if they were not pregnant.
Just another repeat question, again, just regarding the use of CEUS in the placenta. In case you missed Dr. Wilson's answer, yes, CEUS can be used to assess the placenta. It has been used. There are reports in the literature of how it's been used for placenta accreta spectrum assessment. We personally don't have experience with this yet, although we have been asked by our gynecology colleagues to consider incorporating it into our practice. So yes, there is literature on placenta assessment if you wanted to check that out. Comment from one of the participants that most manufacturers use a very low MI for CEUS, usually in the range of 0.05.
Yes, that's totally fine. No, actually, so Stephanie and I are very happy to come and to talk to the audience today because we feel that of course we both love CEUS and we love it for liver and all the kidneys, but we're both definitely supportive of doing pregnant patients and to expanding the use of CEUS to look at the ovary. And certainly our sonographers, we have a fairly small group of dedicated sonographers who most of them do pretty well full-time CEUS. And they're also very, very keen on doing the studies. They have a certain amount of precision and niceness about them. In other words, you can identify the problem, you can see what the results are, and it works very well. So it's it's very rewarding, and the patients are grateful in both circumstances as well. So
our next question asks, will there be an expansion into a clinical setting? So everything we presented today is in a clinical setting. These are real diagnostic cases that were sent to us for workup and in which CEUS directly impacted patient care. So none of this is research. This is all clinical setting, daily practice.
And we are trying to expand both of these applications in the United States. So wherever you're asking from, we hope that you're doing it. But yes, one of our major endeavors always is to increase the utilization of CEUS. And certainly for anybody who ever comes here and visits us or works with us, I mean, it's a very rewarding experience. We seem to deal with problem cases like in the abdomen. Even to this day, we still do many cases that are unresolved after they've had prior imaging, for example. And with the pregnant patients, oftentimes things we find are unexpected, and but still they're alarming when they're first found. So we do find them very, very rewarding to perform these CEUS exams across the board.
Our next question is there any chance of an allergic reaction?
Okay, so safety is a very, very big question, and we just recently had a roundtable discussion, which is recorded and on the ICUS website, about safety. And so in terms of our department, so we have done since 2010, and of course I've been doing it for 10 years before that, but since 2010 we've done 25,000 exams, and those are not injections. There are 25,000 patients who have had CEUS in our department. And we just sent this in to be part of a multi-center collection of safety data, and we have not had any serious adverse events. Since we sent our data in, it's an interesting thing that we did have one patient recently develop quite profound erythema and hives. But that's a very rare thing. But so no, I feel as though relative to CT and MR contrast agents, the adverse event rate is very, very low. And so it makes it a very easy place to work here, right? Like, so we don't come in here thinking that we will have something happen. However, our whole department and all departments that I know of are fully equipped with a crash cart and all of the things that we would need were anything to occur. But no, we do very, very well.
Yeah. So a follow-up to the question about CEUS performance in the clinical setting is also meant like in a private clinic setting rather than just in hospital. So CEUS in private clinics. So Richard, do you...
In the United States, notably by a very famous ultrasonographer, Richard Barr, who wouldn't mind me mentioning his name. He works in Youngstown, Ohio, in a private ultrasound facility or a private imaging facility. And he does exactly what I do. He does CEUS a large part of his day. And so it can happen. However, I personally feel as though it's much, much easier to set up a CEUS operational unit inside a hospital. And that's for several reasons. So first of all, CEUS cannot be done by one person alone. So you have to have one person to inject the contrast because we often do multiple injections, even on the pregnancies and on the ovarian studies. So someone has to inject the contrast and someone has to do the imaging. And so that extra person is more readily available when you're in a hospital. And then the requirement, regardless of whether we have reactions or not, that we must have safety equipment and that kind of thing available to do any kind of vascular injection. Now, of course, you all know that there's private imaging facilities that do CT and MR all over. So yes, it's possible. There's no legislation or regulation that says you can't do it. But we're in the hospital and I like to be here. This is where I like to be. Mm-hmm.
Our next question is, how long is the training for the use of CEUS for sonographers?
So I believe that sonography training is now going to be offered both in Canada and in the United States as an integral active module within all of the training programs. And so if you elected to have education there, then it would be part of your standard training. Now, in terms of didactic teaching is now accepted in both Canada and in the United States as part of the standard curriculum. So sonographers will receive at least basic CEUS education as part of their course.
Our next question is, the bubbles cannot cross the placental barrier, but how about the biodegradation products and how safe are these?
Oh, go ahead.
The short answer is we don't really know about the biodegradation products, and I don't think anybody can really ever figure out if the biodegradation products cross the placenta and into the fetus.
Oh,
so we know, yeah, the microbubbles themselves are too big to actually cross the placental barrier. And then we also know that the biodegradation products from microbubble contrast, after the bubbles are no longer there, that they're rapidly exhaled. And
yeah, like when I was first doing this, when I worked with a very, very renowned physicist, he would always say to the patients, he would say directly to the patients that by the time they walk out of the department, the bubbles are completely gone, that they've breathed out all the gas that's released, like the bubbles go into solution. Mm-hmm. And so that then the gas is just breathed out and it's gone. And the bubbles are encased in a very tiny lipid shell, and that little tiny lipid shell is passed in the kidneys. Mm-hmm. And it wouldn't, what do I think? The biodegradable products are so negligible. Like we inject minuscule amounts of material. And so I think that I don't think there's any chance that they would affect a pregnancy. Done?
Yeah.
So I
Looks-
think, oh, sorry.
No, go ahead, Dr. Wilson.
No, so I think that we've come to the end of our questions. So Stephanie and I have both thoroughly enjoyed speaking to Matt and Sean.
Yeah, sorry, two more.
Oh, have we got two more questions?
Yeah, so two quick add-on questions here. So does rapid washout always occur with malignant masses? Are there instances of enhancement without rapid washout? And what would be the clinical significance?
So that's a loaded question. So there's no doubt about it that the very first paper that we wrote, which is now more than 20 years ago, it was noted in a study of almost 200 patients that the most sensitive CEUS indicator of malignancy is washout. And so in all those years since we first wrote that very first paper, washout is always something that makes us think about malignancy. And rapid washout occurs with masses in the liver that are non-hepatocellular. So metastases and cholangiocarcinoma wash out very rapidly, and hepatocellular carcinoma washes out, but more slowly. And so those are just tremendous guidelines. Now, having said that, if I was showing you a paper on liver masses, there's exceptions. So there's other things that happen, and but nonetheless, yes, washout is highly suggestive of malignancy, and we look for it constantly. We're meticulous about protocol to look for washout.
Yeah, I think some of the non-malignant things that do rapid washout are going to be inflammatory pseudotumors. So to keep that in your mind as a differential,
Yes.
as well. Are there any patients who reportedly taste the enhancement agent when administered in the self-same manner that some patients describe tasting saline with injection?
No.
I've never had that described to
No,
us.
never had that.
Is there an experience with using contrast agents with suspected vasoprevia? Not us personally,
But yes.
It's been done. Question: do you have any experience with CEUS in ectopic pregnancy, and can it be useful?
We have no experience, and so I don't know what the answer is, and I don't know. But I don't. That would be like using it in an acute abdomen situation.
I'm not sure. Or yeah.
No, I don't know exactly what we would do there. But no, I feel no, and I don't think it's something that I've read about using it for ectopic pregnancy either. So if that's the end of our questions, yeah, thank you, Stephanie, for coming to be with me today. And thank you to all of you in the audience. I hope that you've learned something. I hope that you'll increase the amount of microbubbles that you inject in the next little while. And Matt and Sean, thank you very much for Northwest support always, and wonderful conduct of our webinar. Thank you. Goodbye.